We previously discussed the ethical theory of principlism, and like all ethical theories, principlism is still a theory because it cannot be held universally true. There are still holes and gaps, and a key concept that is essential for success in this course is a solid understanding that bioethics needs to go beyond the theory of principlism. When you are analyzing ethical dilemmas, you need to look beyond the belief that any and all medical dilemmas can be reduced to the core principles of the Belmont Report. As you're going to see in this PowerPoint, principlism is not sufficient in and of itself without application of additional theories and concepts to take us through the majority of the bioethical dilemmas that you are going to be faced with. Upon completion of this lecture, you should be able to discuss the concerns that exist when healthcare ethics is limited to only using the ethical theory of principlism. Because of that, you're going to need to be able to explain the critique of autonomy and describe Callahan's principles and theonomy principle, which offer some alternatives to relying exclusively on principlism and relying so heavily on the concept of autonomy when analyzing ethical dilemmas in healthcare. Principlism was a powerful impetus to rethinking the role of the healthcare provider. Principlism was devoid of religious terminology and concepts. The Belmont Report was drafted largely by philosophers, and thus the report set forth an objective, nonpartisan, philosophical, ethical framework and defined a range of patient rights inspired by neglected needs that came to be known as the Belmont Principles. Principlism was originally intended as a set of guidelines for human experimentation, emphasizing informed consent, assessment of risks versus benefits to the patient, and providing guidelines for the selection of human subjects within research and experimentation. The core of the Belmont Report was 4 principles: autonomy, non-maleficence, beneficence, and justice. These principles were, in effect, constructed as extensions of 2 primary responsibilities: the time-honored primary and overriding duty of the healthcare provider to the patient, and the state's responsibility to protect its members. These four principles soon found their way into the general literature of medicine and healthcare, and through this process grew from the principles underlying the appropriate ethical conduct within research into the basic principles of bioethics. These four principles constituted an appealing philosophical framework for efficiently analyzing bioethical cases and provided a rational structure for justifying moral judgments. Their eminently rational or self-evident value is touted to this day. The age of medical paternalism, when the doctor alone decided what was best for the patient, is now over. Since the onset of principlism in the writing of the Belmont Report, came forth the age of patient autonomy, where the patients would choose their own medical treatment. The understanding of principlism is often referred to as an Enlightenment ideal of a universal understanding that permits all people to make arguments for their own conceptualization of a good life. And furthermore, political and social arrangements should not permit anyone to impose their conceptualization of a good life upon another. So, in other words, principlism can be interpreted as a theory that emphasizes self-governance, liberty, rights, individual choices, and following one's own will. Thus, principlism quickly set the stage upon which powerful ethical arguments could be made and defended based on an individual vision of what constituted a good life. The Belmont Principles provided a principled basis for the strong commitment to patient autonomy and a rejection of medical paternalism. The core principles underlying the Belmont Report and their applications have served for decades as a leading source of guidance regarding the ethical standards that should govern research within human participants, and more broadly, policies and decisions on a range of issues in the clinical setting, from truth-telling to informed consent to participation in research, advanced directives, privacy, and confidentiality. Inevitably, all of these orbit around the right of the patient to make decisions about their medical care without the influence from the care providers. Driving most discussions about the core principles of the Belmont Report and their application is the overriding assumption that healthcare providers may educate patients, but should never make medical decisions for the patients. At the time of its development, principlism was intended to be an objective, nonpartisan, and normative ethical theory that could be applied through all areas of healthcare. However, the theory did not live up to much of what it promised. Principlism was embraced as being a neutral and universal moral language for explaining what was good and not good, what should be done and should not be done by care providers in medicine. However, it was neither neutral nor universal. Principlism was speaking to a particular time in history and to a particular place. It was largely influenced by Western Anglo-American bioethics. All of the four principles within the Belmont Principles were intended to be taken into account and no one of them was supposed to overrule another when analyzing an ethical dilemma. Each of these principles were to be prima facie, meaning always binding unless in conflict with other duties. However, what actually occurred was a dominance, a primacy, and an overemphasis of the principle of autonomy over all of the other principles within bioethics. Principlism was supposed to provide us a structure for analyzing and solving moral problems. However, through the use and application of principlism, it separated the individual patient from their social and temporal ties, from their community, and from their history, and it severed individuals from their source of moral meaning. Principlism was to be a method to address concerns about the concrete circumstances of clinical life. However, it was not concrete. It provided abstract principles that were very often open to not just multiple interpretations, but opposing interpretations. Like all ethical theories, principlism had its holes and its gaps. As we discussed, principlism provided a Western Anglo-American outlook on bioethics. The gap here is that principlism failed to take into account how race, culture, and religion shape one's views of medicine and therefore shape bioethics. Principlism provided the respect of autonomy of the self. However, it didn't ground the self in anything enduring, such as community or God. The self was simply the autonomous self. Principlism addressed the doctor-patient relationship or the healthcare provider-patient relationship from the viewpoint of the rights of the patient and the responsibilities of the care provider. However, the theory offered little insight on the responsibilities of the patient and the rights of the provider and society. Principlism has generally been adopted as the ethical framework for healthcare. Yet, at its very foundation, the theory provides nothing about the meaning of providing healthcare. And although principlism emphasized individual patient choice in medical matters, that the patient should have a choice, the theory was silent on the choices themselves and if there were any limits and how limits should be imposed on the choices patients are making, especially when those choices are in contradiction to beneficence, non-maleficence, or justice. As discussed previously, autonomy provided some answers, but it still left holes and gaps in analyzing ethical dilemmas. In no way do I mean to conclude that principlism should fail as an ethical theory. Like all theories, principlism has nuggets of truth. It has strengths. It brought the language of individual rights into the clinical setting at a time when healthcare was ruled by paternalism. The 1979 Belmont Report gave patients a much-needed voice in decision-making and established a basis for moral consensus within a pluralistic society with both secular and sacred traditions. But, like all other theories we have discussed, principlism had gaps. It had holes. It left bioethics unmoored from the larger questions of human nature and reality, the questions surrounding truth and meaning, surrounding transcendent values and destiny. Instead, principlism overemphasized patient autonomy and de-emphasized the principles of non-maleficence, beneficence, and justice. And as we're going to learn throughout the rest of this course, that most of the ethical issues and dilemmas that you're going to be faced with are more complex than simply honoring an individual's autonomy. So, while principlism can work as an ethical theory, it cannot work in isolation without the consideration of additional ethical theories. At its core, principlism boils down to the concept of honoring autonomy. The theory is procedural, legalistic, and stringent. Yet, it can lead to us as humans as feeling betrayed when we follow this concept of autonomy with such stringent rules and regulations, because people aren't algorithms. Every individual case in healthcare is unique and individual and nuanced. And to help explain this point better, I'm going to read to you a case study from the 2012 edition of Bioethics in a Cultural Context by Vincent Berry. The patient was a 17-year-old girl from an Orthodox Jewish community on the East Coast. 3 weeks prior to her hospitalization, the young woman had consulted with her rabbi about Jewish laws covering her upcoming arranged wedding to a young man she'd met only once. In the medical phase of marital counseling, the woman was found to have dysfunctional uterine bleeding, which subsequently was tracked to uterine cancer. Dr. John Lantos and his colleagues recommended radiation followed by a hysterectomy, which would leave the woman infertile. But the young woman's father feared that the news would devastate his daughter and jeopardize the wedding. So he requested that she not be told that the treatment would leave her infertile. Of the decision he faced, Dr. Lantos wrote, "In one sense it was easy. Informed consent, respect for persons, truth-telling. From a risk management point of view, it was a no-brainer. You tell her. If she refused treatment, that's her choice. It may be tragic, but it isn't tort. Treat without consent, and she sues later. It is at least malpractice, and maybe assault and battery." From a principlism perspective, then, the right course of action seemed clear-cut. Tell the patient the whole truth. But on second thought, the matter was a bit more complex. Whose interests were paramount, the patient's or the hospital's? And what about the principles used to decide? The Belmont principles were neither timeless nor universal. Had the young woman not been in the United States, for example, or had it been a few decades earlier than the 1990s, perhaps nobody would have told her. She was, after all, a minor, and her concerned and sincere parents had the legal right to decide for her. Then there was the matter of her religion, which didn't acknowledge the primacy of autonomy. As her father said, she must have treatment. Law requires it. Why add to her suffering now when she needs hope and strength? When the young woman was told the whole hard truth, she said she didn't want the treatment and stormed out of the room, leaving Dr. Lantos questioning his decision. Did we do the right thing? We followed all the rules. Our actions were based on adherence to the most idealistic moral principles. In a certain sense, what we did was unassailable. In the most difficult and trying circumstances, we had confronted ugly truths instead of hiding from them. We had helped a patient who clearly had the capacity to make her own decisions to understand the choices before her, and to make a choice based on her own deeply felt moral values. This was a triumph for patient autonomy, for feminism, for children's right, a culmination of 25 years of work in health law, civil liberties, and bioethics. But it felt as if we had betrayed everything that medicine stands for and had become zealots in a cause that looked less like moral excellence and more like political dogma. Although Dr. Lantos did what he ought to have done according to principlism, in retrospect, he was not persuaded that he best served this young woman. In fact, he felt that he placed physician and institutional values and interests above his patient. Although he studiously acted on principle to avoid wrongdoing, both moral and legal, he somehow felt that in this instance he and the philosophy of principlism failed the test of moral excellence. Dr. Lantos is hardly alone in feeling betrayed by principlism. For many healthcare providers who have spent the time and effort to really understand this ethical theory, it is often considered that doing the right thing is nothing more than a risk management strategy to avoid civil wrongs such as tort, malpractice, assault, and battery. In other words, following the rules is not the same thing as moral excellence. Following the rules is not doing what is wrong. Moral excellence goes one step further and looks at doing what is right. And if you recall, there's a difference between what is right and what is correct. And when what is right and what is correct by the law don't always align, that is where we have to ask, does principlism fail the test of moral excellence? Will principlism lead us to doing what is right, or just lead us to doing what is legal and what will mitigate risk? As ethicists continue to evaluate principlism, there has been this growing consensus that limiting the analysis of ethical dilemmas to principlism produces very thin gruel. It does not provide a substantive argument for addressing the complex moral decisions that must be made in healthcare. And this is because when we rely on principlism, we are relying on autonomy, which largely is grounded in the legal concept of informed consent. And when we look at the interaction between the care provider and the patient as just a contract of informed consent, other ethical principles and values and considerations become neglected. Informed consent is to the detriment and limitation of considering existential and spiritual aspects of the patient-provider relationship. And it also neglects an understanding of the larger vision of societal goods and human ends. And you may be thinking that informed consent is very important and essential in healthcare. And it is important, but there are very few things that we can say in absolutes So I'm not going to say that informed consent is always essential, and we'll get to that on a couple of slides later. But if informed consent is the only thing we are considering, we are missing the larger application, the bigger picture, the other facets and factors that need to be considered in an ethical argument. Principlism matters. Informed consent matters. But we have to ask ourselves, at the end of the day, can all medical dilemmas be reduced to the application of principlism and informed consent? You may be feeling right now like the concept of patient autonomy is under attack. And in a way, it is. Many of the critics of principlism view this overemphasis on autonomy as neglecting the texture of human values and the complexity of bioethics. And many critics say that principlism can't stand up to that complexity, that autonomy is not the be-all end-all, and thus a theory that relies so heavily on individual choice of the patient should be stringently analyzed before accepted and applied universally. On the previous slide, I warned about relying solely on principlism when responding to ethical healthcare dilemmas. Now I'm going to focus on the critique of autonomy. One of the big concerns with relying on principlism is an over-reliance on patient autonomy. And there are a lot of concerns when ethical decision-making is completely reliant on the autonomy of the patient. At its most extreme, the over-reliance on autonomy impoverishes bioethics. This negates Kantian and utilitarian arguments. No longer can the healthcare provider have a duty of doing what's right. Their duty becomes doing what the patient wants. No longer can we have a utilitarian argument of doing the greatest good for the greatest number and considering what is best for the whole. The focus becomes the individual patient. And furthermore, when we look at what is right and what is wrong, when we focus on autonomy, the answer no longer becomes balancing autonomy with beneficence, non-maleficence, and justice, but what is right and wrong becomes what are the wishes of the patient. And we're going to look in this course about how much autonomy drives public policy. And the problem here becomes when the autonomous views of one are the driving force, there is less focus on the common good. Furthermore, patient autonomy disallows for conscientious objection. In other words, the autonomy of the individual patient negates the autonomy of the healthcare providers. And therefore, this minimizes the role and responsibility of healthcare professionals to ensure that patients are getting what they want. So it's almost like we go from the extreme of medical paternalism to now this extreme of patient autonomy, where the education and the training and the knowledge of the providers is a moot point, which means that autonomy has started to override professional judgment. And we have to worry about, is this ethical, that we are doing what the patient wants even when we know it is directly harmful to the patient? Where should that line be drawn? And how much ability should healthcare professionals have to provide beneficent care? And at what level are healthcare professionals responsible for providing beneficent care in opposition to the wishes of the patient. And this especially becomes important when you have somebody speaking on behalf of the patient. There are three primary tenets to the critique of patient autonomy: the impoverishment of bioethics, the disallowment of conscientious objection, and the overriding of professional judgment. And we're going to look at each one of these in detail on the upcoming slides. What do I mean when I say that autonomy is impoverishing bioethics? What I mean is that critics have argued that the preeminence of autonomy is emptying ethics of its content. The principle of autonomy has crowded out of bioethics both deontological and utilitarian arguments, leaving patient treatment choices as a quasi-absolute moral value and normative standard. In other words, we are no longer worried about duties or outcomes. The only concern is patient choice. And when this is the focus, neither bioethicists, doctors, other care providers, or patients are required to justify their choices in terms of any moral principle. The overriding concern is simply whether or not patient autonomy is respected. And this avoidance of moral acceptability of issues then technically renders the discipline of bioethics obsolete. Second, when the emphasis is on autonomy, any consideration of goods and values that make choices right or wrong are excluded from the picture. However, these goods and values are often the key factors that make bioethics a moral enterprise. These goods and values are what either support or undermine or promote or harm an individual. Yet, when the rightness or wrongness of a choice is reduced to the single factor of the freedom to choose, morality is impoverished. Third is autonomy has gone beyond being merely a means to a good. Autonomy has caused the loss of the moral commons in medicine. And what is moral commons? Moral commons refers roughly to the specific good that is shared by and beneficial for the community at large. And the idea behind this is that the more consideration of individual autonomy, individual choice drives public policy, the less consideration is given to the common good. We are so focused on giving individuals freedom to choose that nobody is really looking into anymore how these individual choices are impacting the common good. No one is considering the ripple effect of the choices. And finally, autonomy is an extension of an Enlightenment political and social philosophy that fails to ground the moral character of medicine. And it's overlooking the commitment and the role to beneficence, this obligation of healthcare providers to do good. And it's overlooking the professional responsibility to restore health and reduce suffering. And while autonomy is important, unless we are balancing it against these responsibilities of the care provider, It is simply a law. It is not a moral or ethical consideration. The second tenet of the critique on autonomy is that autonomy disallows conscientious objection. As we have discussed, the primacy of autonomy has come to mean that care providers must faithfully honor patient-informed consent by disclosing all options, including a risk assessment, and allowing patients to choose among these options. But where does this leave provider autonomy? Is it the sole purpose of those working in healthcare to ensure patient autonomy? Those critics have argued that strict patient autonomy diminishes professional autonomy and diminishes professional responsibility by making healthcare providers mere vendors of goods and services. In other words, an emphasis only on autonomy disallows and disapproves conscientious objection of any treatment modality on the part of the care provider. Autonomy can pit professional conscience against patient choice. It is widely acknowledged that care providers should not have to engage in practices that violate their morals or their religious beliefs. However, it is also widely acknowledged that patients should have access to legal treatments that may morally trouble healthcare providers, which leads us to some very serious questions that go beyond just considerations of autonomy. Is it ethical for healthcare professionals to describe their objections to patients? Should they keep their objections to themselves, or are they obligated to disclose them? Should healthcare providers refuse to discuss, provide, or refer patients for medical interventions for which they have a moral objection to? And this really comes down to controversial treatments and controversial options. And if the care provider has an objection to a treatment or to an option, to what degree are they obligated to share that treatment or that option with the patient? And at what level does this disallowing of conscientious objection take away from autonomy and lead to a culture war over who views what as right and wrong? Are we missing the bigger picture here by focusing so heavily on everybody's autonomy? The third tenet of the critique of autonomy is that an overemphasis on autonomy overrides professional judgment. And unlike the second tenet, conscientious objections, which has to do with the moral integrity of the healthcare professional, professional judgment has to do with upholding beneficence. And it brings forth this concept of the placebo effect, which is a long-known phenomenon in which patients are given a fake or ineffective treatment that often causes improvement simply because the patient expects to get better. The ethical consideration here is that there is an element of deception with placebos, which is contrary to the principle of informed consent. However, doctors who use placebos say they are merely helping their patients get better. So, is it ever ethical for a provider to deceive a patient for their own good? It's currently estimated that about 72% of providers prescribe placebos, and they view it as ethical because it is generating the result that the patients want. And one often argues that most patients would gladly be duped by a placebo if it is the only way to get relief. So, if what the patient wants is relief, and what the provider is providing to them is relief, is there any harm in the patient not knowing that this is a placebo? Is it worth violating the patient's autonomy to promote the beneficence of the good outcome? And then the other angle of this is when the patient preference doesn't align with the professional judgment, knowledge, and expertise of the care provider. At what point should the care provider allow or approve a treatment that a patient desires, but the provider feels is in opposition to providing the safest, most high-quality care to the patient? Should the patient simply receive what they want in all circumstances because they want it, despite the knowledge that the care provider has? Where should the line be drawn regarding balancing patient autonomy and professional judgment? So I talked about the fact that principlism shouldn't be used on its own to analyze ethical dilemmas. I talked about principlism being very thin gruel and lacking depth and substance. And many of the critics of principlism have suggested procedural offsets to this emphasis on autonomy. And we're going to talk about some of those. Callahan has offered two principles, the ecological principle and the vital institution principle. And religious advocates have offered a biblical alternative to this emphasis on autonomy, which has been termed theonomy. So we're going to take a little bit of time to investigate these offsets for autonomy in bioethics. Critiques of autonomy that we discussed have led some bioethicists to suggest that there needs to be procedures to offset the principle of autonomy. Callahan is one such bioethicist who has provided two principles, the ecological principle and the vital institution principle. Both of these principles are deemed utilitarian in nature. The ecological principle disallows the claim of autonomy until after a thorough review of both incremental and intangible harms has been completed. When a decision is made autonomously, it should be evaluated for the risk of incremental harms. Is the decision an act that, while individually causes little or no harm, may have a dramatic effect when taken together? So this is really looking at what type of ripple effect does this act have. An example of this would be somebody runs a stop sign when there are no other cars around. That causes little or no harm in that specific instance because there are no other cars. However, if we incrementally allow the running of stop signs, there can be a long-term dramatic effect. Intangible or symbolic harms are acts that are considered wrong not because the act caused harm, but because the act itself violated an important value or an important principle. So for some people, an example of an intangible or symbolic harm might be the use of embryos for research. while nobody in some cases maybe caused physical harm from this, that some would say that this is a violation of human dignity and human rights. Callahan's second principle, which is also grounded in utilitarianism, is the vital institution principle, which restricts individual liberty when a person's autonomy threatens the vital social interests and institutions. And basically, what this is saying is that there needs to be a higher authority than the individual, whether from the secular view, such as Callahan, that this higher authority needs to be the social interests and institutions of the law, or whether this higher authority is God. Either way, for an autonomous act to be deemed ethical, it needs to be sure that the act will not cause harm and that the act does not go against whatever the higher authority is, be it the law or be it God. Theonomy, which literally translates to God's law, is a Christian form of ethics that is also in opposition to autonomy. Theonomy is the view that the Bible contains God's plan for personal and social ethics, and therefore theonomy is in opposition to autonomy because under autonomy, the self would provide the basic foundation of ethics. Participated theonomy applies the ethical theory of religious natural law and explains that human beings are by nature free and self-determining, but we also have a relational character. Therefore, to understand the meaning of value, we must consider both the autonomous individual and the relational individual. The individual who is making decisions for themselves at the same time as the individual that is making decisions in relationship with others. Because of being created by God, we share a divine kinship. Therefore, according to participated theonomy, we are only free to the extent to which we choose to give ourselves to others. So this goes back to the concept of free will, and that really the true freedom and autonomy that humans should have is not that humans make the foundation and basis for ethics, but that our autonomy lies in our ability to choose to follow God and choose to do as God would will. So now what? The quintessential question, now what? I've gone over a plethora of ethical theories with you. I've discussed with you the limitations of all of the ethical theories we discussed. I provided you with the quintessential ethical theory of bioethics and then spent an entire lecture tearing apart that theory. At this point, you may have a more complex set of questions about ethical theories than you started the course with. When you started the course, you may have had a very limited or minimal understanding of ethics. And now, not only are you trying to wrap your head around ethics, but I've given you a list of theories that none of which can stand on their own. And we are getting ready and preparing to apply our knowledge to actual circumstances. How are you ever going to do that when there is no theory that is universally applicable? There is no ethical system that was free from questions or potential problems. Now what? What you now are tasked with is finding the nugget of truth in the theories. Finding and pulling out what bits and pieces of each theory make sense to you, the bits and pieces that align with your worldview and your personal ethical framework. Do not fall into the trap of disregarding the other ethical theories and relying on principlism solely to respond to ethical dilemmas in healthcare. At this point, what you need to do is review the ethical theories, including principlism, identify the nuggets of truth, and identify the gaps and the holes as you develop your own framework. You're going to find that once you do that, you have more answers than you thought you did.